So here, question 16, we have a 55-year-old man complain of diarrhea, abdominal pain, and weight loss, and joint pain. So here, the chief complaint of diarrhea, abdominal pain, weight loss, and joint pain with 2 or 3 daily bulky stools. So, on examination, abnormality is detected apart from, no abnormality has been detected apart from angular stomatitis. So we have angular stomatitis and flat pale tongue. An OGD was performed and the duodenal biopsy show subtotal villus atrophy. Subtotal villus atrophy is very characteristic. On the top of the differential, it's going to be celiac disease. So you have to think about celiac. Which of the following is recognized complication for this condition? Which condition? It's celiac disease, most likely. Cirrhosis, it's unlikely, it's not a recognized complication. Colorectal carcinoma, it's not a recognized complication. Enterocyte-associated T-cell lymphoma, this is a recognized complication of celiac disease. Esophageal varices is not a recognized complication. Pancreatitis is not a recognized complication. So there are 3 types of cancer associated with celiac disease. Enteropathy-associated T-cell lymphoma, and non-Hodgkin lymphoma, and adenocarcinoma of the small intestine. It's important to remember, however, the developing cancer due to celiac disease, it's quite rare. But the most recognized complication, it is lymphoma, T-cell lymphoma, from these options mentioned in this question. So let's move on to question 17. A 48-year-old lady has an ulcer in her right foot for the past 6 weeks. It is not painful, so it's painless ulcer. The ulcer is in the plantar aspect of the head of the first metatarsal. It has undetermined edges, and base of the ulcer is sloughy with a lot of exudate. She has a background history of type 1 diabetes mellitus and hypertension, obesity, and 30 back year history of smoking. Her ankle brachial index is 0.91, with a digital brachial index is 0.74. So digital brachial index is reduced, so this indicates that we have element of chronic limb ischemia or peripheral vascular disease with a chronic limb ischemia. And the other things here, we have the patient has a history of diabetes mellitus and has painless ulcer in the plantar aspect of the foot. So this indicates that we have neuropathic component of this ulcer, which is diabetic foot ulcer. So what type of ulcer does this lady have? This is mixed type of ulcer. I think it's neuropathic with vascular or neuropathic with arterial ulcer. So it is arterial ulcer alone. I think this is not arterial ulcer alone. Mixed neuropathic and arterial, I think this is the most appropriate. It is mixed neuropathic and arterial ulcer. Mixed venous and arterial ulcer, I think it's unlikely. Neuropathic alone, it's unlikely. Venous ulcer alone, this is unlikely. So mixed neuropathic and arterial ulcer. So question 18, 79-year-old gentleman is being followed up by the vascular team for the asymptomatic abdominal aortic aneurysm. A year ago, it measured 3.5 centimeter, its maximum diameter. Today, on a repeat scan, it's now measured 4.6. So this is very important, 3.5, and now it is 4.6. So over 1 year. So this is increase in the diameter of the abdominal aortic aneurysm more than 10 millimeter or more than 1 centimeter. And this is the definition of rapid expansion, or this is the definition of rapid enlarging of abdominal aortic aneurysm, or rapid expanding abdominal aortic aneurysm. The definition of rapid expanding, it is either increase more than 5 millimeter, which is 0.5 centimeter over 6 months, or enlarging more than 10 millimeter, which is 1 centimeter over 12 months, which is 1 year. So here we have rapid expanding abdominal aortic aneurysm or rapid enlarging abdominal aortic aneurysm, and this is one of the indications for surgical intervention. So what is your next plan for action for this patient? Arrange for surgery or CT scan in 6 months and just follow up, or duplex scan in 1 year and just follow up, or duplex scan ultrasound in 3 months, just follow up, or duplex scan in 6 months. I think the most appropriate here to arrange for surgery. Arrange for surgery. Indication for surgical intervention in abdominal aortic aneurysm, it might be emergency indication if it's ruptured. It might be an semi-urgent indication if it is symptomatic. It's called semi-urgent. indication if it's symptomatic, which is tenderness on palpation of the aneurysm. And it could be elective indication. Elective indication of the abdominal aortic aneurysm size more than 4.5 centimeter in men or more than 5 centimeter in women. And the other things, the other indication, it is rapid expanding abdominal aortic aneurysm, and the definition of rapid expanding is increasing in the size more than 5 millimeter over 6 months or more than 10 millimeter over 1 year. And there is other sometimes indication, like if the patient has asymptomatic abdominal aortic aneurysm that does not meet the criteria for surgical intervention, if the patient has symptomatic peripheral arterial disease or peripheral vascular disease, or if he has peripheral aneurysm, other peripheral aneurysm like iliac or femoral aneurysm. So here we have the most, I think the most appropriate step here, it is to arrange for surgery. So question 19, 69-year-old lady present to emergency department with right-sided hemiparesis. So acute onset of neuro symptoms or neurological deficit. She gives a history of slurred speech this morning, which has now subsided. So her symptoms, slurred speech and neurological deficits, they are all subsided. She is right-handed. She is right-handed. What is the first imaging investigation you will request here? The most likely we have TIA. It is transient ischemic attack. Most common cause of TIA, it's carotid stenosis. So I think the most appropriate first imaging investigation you will request, it is here we have the options: carotid duplex scan, which is carotid ultrasound, or CT brain, or CT carotid angiogram, or CT cerebral angiogram, or echo. So I think the most appropriate first investigation or first imaging you have to start with, carotid duplex scan. Carotid duplex scan. I think this is the most first imaging investigation you will request as an initial imaging investigation, carotid duplex scan. So here we have question 20, 72-year-old female with no significant past medical history, collapsed while exercising. So here we have exertional collapse or exertional loss of consciousness. She has intermittent exertional chest pain. So she had exertional chest pain as well, and dyspnea on exertion. Her physical examination revealed a grade 3 late peaking crescendo-decrescendo murmur at the right upper sternal border. This is right upper sternal border. This is aortic area or aortic valve area. So here, aortic valve area, we have crescendo-decrescendo murmur and a grade 3 holosystolic murmur. So holosystolic murmur at the apex. Her S2 heart sound is very soft, and her carotid upstroke is weak and delayed. So weak and delayed carotid upstroke, this means pulsus parvus and yet tardus. Pulsus tardus yet parvus and tardus. This is the characteristic for pulsus parvus yet tardus. The upstroke, it's weak and it's delayed. Comparing to the normal, if we can see the normal presentation of carotid pressure, this is the normal presentation. So the upstroke must be acutely and strong, and the downstroke must be as well, acutely and quickly. So in patient with this pathology, which is most likely it's aortic stenosis, the patient will have this waveform in the carotid. This waveform is called carotid upstroke weak and delayed, or it's called pulsus parvus yet tardus. Delayed carotid upstroke, it's called tardus, and the weak carotid upstroke, it's called parvus. So which of the following is the most likely causing of the symptom? Is it aortic regurgitation, aortic stenosis, mitral regurgitation, or mitral stenosis, or mitral valve prolapse? Most likely it's aortic stenosis. So here, most likely it's aortic stenosis. So I will finish this video and this question, and I'm going to discuss the other question in coming video. Thanks for watching this part of the discussion.